Thank you. So, pain in abdomen can be of two types, visceral pain and parietal pain. It is important to differentiate between the two because the differentials will be accordingly. Visceral pain is vague in nature, they are poorly localized, patient is not able to pinpoint the site of the pain, and visceral pain arises from some viscera, and if the viscera belongs to the foregut, then pain is perceived in the epigastrium, and if it is midgut structure, then pain is perceived into the periumbilical area, and in hindgut structures pain is perceived in the hypogastrium. So, the localization of the pain depends on the embryological origin of the organ. Parietal pain are sharp, well localized pain. It corresponds to the segmental nerve roots. As I said, the acute abdomen is painful surgical emergency. So, what are the causes for the acute abdomen? It may be bleeding like ruptured arterial aneurysm, ruptured ectopic pregnancy, bleeding from GI diverticula, aortoduodenal fistulas, hemorrhagic pancreatitis. So, these are causes for the bleeding causes for the acute abdomen. Then may be inflammatory infectious causes like appendicitis, cholecystitis, diverticulitis, abscess. So, these can present as a acute pain abdomen. Then comes perforation. It may be perforated diverticulum, perforated ulcer, perforated malignancies, or a perforation into the lower esophagus, something called Boerhaave syndrome. Boerhaave syndrome is the perforation into the lower esophagus. And other causes for the obstruction, pain may be obstruction, luminal obstruction like volvulus, adhesions between the bowel loops leading to the obstruction, hernias, obstructed hernias, inflammatory bowel disease leading to the stricture formation, intussusception, and neoplasm. Then there may be ischemia. Ischemia like related to the peripheral vascular disease, Bardet disease, maybe mesenteric thrombosis, ovarian torsion, ischemic colitis, strangulated hernias. So, these all are differential diagnosis for the acute abdomen depending on the presentation. So, these previous list of these were the causes, the surgical causes, but there may be non-surgical causes of acute pain abdomen. These are medical causes that presents as acute pain abdomen like diabetic crisis, uremia, acute intermittent porphyrias, Mediterranean fever, sickle cell crisis, and other poisoning, especially lead poisoning. They all present as acute pain abdomen. So, these are the medical conditions presenting as acute abdomen. So, this completes the list of differential diagnosis of acute pain abdomen. Patients usually present into the emergencies. So, where we have limited time to investigate and evaluate the patient, we have to provide the treatment immediately and treatment depends on the cause. So, we have to make a quick diagnosis, and most of the time depending it is based on the history and examination. We might be having very few investigations in emergency. So, the detailed and organized history is very important, and as the pain is the characteristic feature. So, the detailed history of pain is of utmost importance. So, we learn something about the pain again. We discussed about the pain differences between the visceral and parietal pain, but if the patient is presenting with sudden onset severe pain, then most likely it is either intestinal perforation or embolization leading to the acute ischemia. So, sudden onset severe pain often signifies a perforation or embolization leading to the ischemia. Pain that evolves over few hours, then it is more likely to be cholecystitis, obstruction and colitis. And if a patient develops gradual pain, then patient will present usually in the OPD and not in emergency. So, if you see whether it is sudden onset pain or it is pain that developed over few hours. And then we try to locate the most painful area, and that may give us indication what organs are involved. If it is in the epigastrium, then usually it is from the foregut. If it is in the periumbilical area, then pain most likely is arising from the midgut, and hypogastrium it is more likely from the hindgut. So, these are the few causes for the pain, that is gradual progressive pain. If it is in the epigastric area, then more likely it is pancreatitis. If gradual progressive pain is in the right upper abdomen, it is more likely from the cholecystitis or hepatitis, and gradual progressive pain in the right lower abdomen is more likely from the appendicitis or some gynecological causes, and in the left lower abdomen it is more likely from the diverticulitis. It is continuous pain, it is not colicky pain. So, all these conditions they lead to the continuous progressive pain. And if the pain is sudden onset severe pain located into the epigastric area, then it is more likely from the perforated ulcer. In the periumbilical area, ruptured aortic aneurysm, and on the lumbar areas and iliac fossas, then it is more likely from the renal origin. So, the onset of the pain and nature of the pain and location. So, we have to put this information together to reach a possible cause for the pain. And if the pain is colicky type intermittent pain in the right upper abdomen, it is usually biliary colic. In the periumbilical area, it is the small bowel obstruction. In the lower abdomen, in hypogastrium, it is the colonic obstruction, and renal colicky pain in the lumbar areas is again from the renal origin. So, the location tells us about the possible site of the origin. If it is periumbilical, then it is from the midgut, that is small bowel. Then again we have to talk about the referred or radiation pain. Referred pain pain from the peptic ulcer might be felt into the right lower abdomen. It is because of the contents that move along the paracolic gutter and get collected into the right lower abdomen. And pain from the ureter is again referred to the depending on the site of the obstruction. So, it should be know what is the possible locations of the referred pain and the site of the pathology. So, this is a list for the some of the referred pains where the pain arises from the abdomen, might be referred to out of the abdomen, like pain in the diaphragmatic areas, especially in the left side. It may be referred to the left supraclavicular area, that is called Keher sign. It is usually present when there is a perisplenitis. Ureteric pain may be referred to the groin or inner thigh depending on the site of the obstruction. Sometimes we may find pain in the epigastric area, that is arising from the cardiac system, not from the abdominal cause. So, the pain from the heart may be felt into the epigastrium also. So, epigastric pain is not always abdominal origin. Appendix that anatomically lies into right lower abdomen, right iliac fossa, but the pain is felt over periumbilical areas. Pain arising from the duodenal ulcer is usually perceived into the epigastric area, but it may be felt into the periumbilical area. Gallbladder pain is felt into the right upper abdomen, but it may be felt into the epigastric areas. And gallbladder pain may be felt into the at the scapula on the same side. So, the referred pain might indicate a pain at one place, but pathology at somewhere else. So, you should be able to know and locate the pathology related to the referred pain. So, this was about the pain. The pain is most important symptom in emergencies and it can lead us to the diagnosis, but it should be supported by associated symptoms also. So, the associated symptoms that may be present there with acute abdomen are nausea, vomiting, constipation, diarrhea, itching, melena, that is bleeding. So, if it is hemorrhagic cause, then there may be bleeding. If it is obstructing cause, there will be constipation. So, you should be able to analyze the pain and associated symptoms. And after this history, we move to the examination. In examination, we look for the movement of the abdominal wall, because if there is a peritonitis, the abdominal wall will not move and patient will lie still into the bed and resist any kind of movement. You have to see whether the abdomen is distended or not, any previous scar mark, in scar mark of the previous surgery, that may tell us about the lead cause. Maybe it is the obstruction, because the surgery leads to the adhesions and obstruction. Then we have to look for the tenderness, guarding or rigidity, and normally the liver area is dull to purcus, and if there is a loss of dullness over the liver area, it means there is a free air into the peritoneal cavity. So, that suggests perforation. So, examination and its findings are guided by the history. Again there are so many signs into the related to the emergencies that you should know. It may be some related to the history, related to the examination. History and examination gives us a provisional diagnosis, and we try to confirm it with our investigation findings. So, the lab investigations that we get into the emergencies are usually the routine investigations like CBC, complete blood count, electrolytes, because obstruction and other things will lead to the vomiting and the electrolyte disbalance. So, we have to correct the electrolyte imbalance before any surgical intervention, and blood urea nitrogen, creatinine it is required if we are planning to get a CT scan. Also, if patient is dehydrated, then we try to know what is the blood urea nitrogen level. If it is pain related to the renal origin, we try to get the urine routine microscopic examination, and if a pain is suggestive of a lower abdomen, patient is young female or childbearing age group female, then we get a beta HCG or a urine pregnancy test done immediately to know whether it is related to the gynecological or ectopic pregnancies, something like that. We get amylase lipase to confirm or rule out pancreatic pathology, especially the pancreatitis. Hepatitis or other biliary causes may lead to the derangement into the liver function test. So, we get liver function test also. Serum lactate level tells us about the ischemia. So, we get an arterial blood gas analysis to look for the serum lactate level, and if it is elevated, it suggests some ischemic organ. Ischemia is an important cause of the acute abdomen, and some infective causes may be found out. So, in emergency we get CBC, electrolytes, LFT, amylase lipase, and an arterial blood gas analysis to look for lactate. These are routine we get in nearly all the patients, and if you are suspecting some gynecological cause, we get an urine pregnancy test also. After lab investigations, we go for some imaging studies, and in emergencies plain X-rays are very important. They can be done at any time, even can be done bedside if patient cannot be shifted to the radiology department, ultrasound, and sometimes CT scan. So, we are learning about the acute abdomen. So, we talk about the abdominal findings of the X-rays. So, X-ray is very important, at least it can tell you about the two conditions that will require urgent surgery. One is the perforation and other is the obstruction. So, most of the time perforation and obstruction can be diagnosed based on the X-rays only. We do not require any other investigation, and these are the surgical conditions that require emergency surgery, and they can be diagnosed on X-rays. So, this plain X-ray chest, the finding is air under right domes of the diaphragm. So, it is the perforation. Simple chest X-ray is sufficient to diagnose a perforation of hollow viscous organ. This is another X-rays of the abdomen, and that shows dilated colon. It may be a volvulus or some other cause for the colonic obstruction. This X-ray, it shows dilated transverse colon, and it is often related to the not because of the obstruction, but because of the pancreatitis. Inflammation in upper abdomen leads to the loss of peristalsis and dilated bowel loop. So, pancreatitis is the diagnosis of pancreatitis is supported by this X-ray. So, if we get an X-ray and if it is perforation, we find air under diaphragm. If it is obstruction, we find dilated bowel loops, maybe small bowel loops or large bowel loops, depending on the site of the obstruction. And if it is not, if it is none of these two, then we might get some other findings. And if it is inflammatory condition, then remember, whenever there is inflammation and if the bowel that comes in contact with that area, inflamed area, there is really loss of peristalsis. So, there may be dilated bowel loops without any obstruction if there is an inflammatory condition. Other investigation that is commonly done into the emergencies is ultrasound. Ultrasound can diagnose few conditions like renal colic, renal stones, gallbladder stones, cholecystitis, appendicitis. So, biliary obstruction. So, they can be diagnosed on ultrasound. So, this is an imaging that shows this is the liver. You can diagnose it. No, it is the liver because of there is a portal veins, and this is the cross sectional image in which the gallbladder is seen into the cross section. You can see this is the gallbladder wall. It is inflamed and that is edematous gallbladder, and there are some fluid, black lines present here near the arrows, and this fluid is pericholecystic fluid. So, edematous gallbladder wall along with the pericholecystic fluid, and this is the same patient ultrasound. There is a stone into the neck of the gallbladder. This elevation, it is because of the stone. We call it stone because there is a shadow below the stone. So, this shadow is called post-acoustic shadow. So, we identify a stone because of its associated post-acoustic shadow. So, there is a stone into the gallbladder along with the edematous thickened gallbladder wall and pericholecystic fluid. So, all these findings suggest acute cholecystitis. So, acute cholecystitis is diagnosed by ultrasound. This is again a sonographic ultrasound image in which the organ imaged is appendix. So, you can make out there is a tubular organ here, there is a tubular organ here, and this tubular organ is closed from the front. So, it is blind ended tubular organ, and there is a black line around the appendix. It is the periappendiceal fluid. Whenever there will be inflammation, there will be some fluid around that inflamed organ. So, thickened dilated appendix with periappendiceal fluid. Again in the cross section you can see this is the appendix and this is the fluid around it. So, and because of the inflammation there will be loss of peristalsis. So, a thickened dilated appendix with loss of peristalsis and fluid around it suggest acute appendicitis. So, these are the features on ultrasound by which we diagnose acute appendicitis. So, ultrasound can diagnose acute cholecystitis, appendicitis, and again this is the CT scan that is done for a appendicitis. Again you can find there is a appendix that is dilated and inflamed, and this is CT scan of another patient, it is not of the same patient, and that shows there is a collection, there is some pus collection around the area of the appendix. So, it suggests about the perforated appendix leading to the pus collection. So, the complicated appendicitis, if you know why we got the CT scan, because when we discuss about the management of appendicitis, if it is simple appendicitis we go for surgery, and if it is complicated appendicitis then and pus is there, then often we do not perform surgery, we try to get more investigation to characterize the collection and then do something to drain the pus. So, the objective is our plan of the management is to drain the pus, and it can be drained without surgery. So, if we are suspecting complicated disease, then we go for CT scan to further look for the complication. These are the CT scan cross sectional images done in a patient with the presenting with the acute severe pain abdomen of epigastric area. So, you may find that it is the pancreatitis, there is a stone into the and there is a pancreas is inflamed. So, inflamed pancreas, this is the inflamed pancreas with stone, that suggests presence of the biliary pancreatitis. So, these were the few investigations of the common problems, and this is the algorithm to make a diagnosis into and a management plan in emergency. In emergency, patient presents with the acute pain abdomen, it is the acute onset pain. Then we go for examine and look for the peritoneal signs. Peritoneal signs means if there is a guarding, tenderness, rigidity or not. If there is none of these peritoneal signs are present, then it may be ischemia or other cause. So, we look for the acidosis and elevated lactate and get a CT scan. Ischemia is better diagnosed on CT scan only. So, if there are acute onset severe pain without any peritoneal features, then it is more likely to be ischemia, and it is called where the pain is out of proportion to the signs on examination. There will be severe pain without any physical finding. So, it may be we get a CT scan, and if on CT scan we find the blockage into the arterial system, then it is arterial ischemia, and depending on the extent of the ischemia and severity, we plan whether to operate the patient or go for radiological intervention to remove the obstruction. We can stent the obstruction, we can remove, give thrombolysis. So, we can do interventional radiological intervention to treat the arterial blockage, but if there is a associated gangrene of the bowel, then we have to operate and remove the gangrenous segment. So, this is on the right side, it is the algorithm for the ischemia, bowel ischemia, and if there is a mesenteric venous thrombosis, the treatment is anticoagulation, and if there is a presence of bowel gangrene, then we go for surgery. And if CT scan does not show any obstruction or any cause for the symptom, then we consider diagnostic angiography. that has better sensitivity. But if the acute onset severe pain is associated with the peritoneal signs, we get abdomen X-rays, and if there is a pneumoperitoneum on abdomen X-rays, then it suggests hollow viscous organ perforation, and patient needs immediate surgery. And if there is no pneumoperitoneum, then more likely it is obstruction. Because X-rays has a sensitivity of around 80% for detecting the pneumoperitoneum. If there is no pneumoperitoneum, it does not mean there is no perforation. It may be that perforation has sealed off, so or the leakage of air is not that much, or there may be adhesions. So, the air cannot reach up to the diaphragm. So, we get water soluble contrast fellow to look whether there is a leak or not. If there is a leak, then again we go for the surgery. If there is no leak, then get a CT scan, and if there is a contained leak, then we go for the surgical intervention. So, this is the algorithm for the acute abdomen. So, acute pain abdomen, if it is because of the obstruction or perforation, most often they require surgery, and if it is because of the inflammatory condition like acute cholecystitis, appendicitis, they might be or pancreatitis, they might be managed on conservative route also. So, the preparing a patient for the emergency surgeries, we have to get an IV access, because patient might be dehydrated. We have to rehydrate the patient, correct any electrolyte imbalance, start with the wide spectrum antibiotics, and put a Ray's tube, nasogastric tube to decompress the stomach and upper small bowel. And few things about the peritonitis. Peritonitis is the inflammation of the peritoneum. It may be localized or generalized. So, peritonitis may be localized to the one area of the abdomen. It may be primary or secondary, and most of the time the bacteria that causes the peritonitis comes from the GI tract. So, it is the more common. These E. coli, bacteroids, streptococci, they are Klebsiella, they are the bacteria, they present into the colon or small bowel. There may be other causes of the peritonitis, like presence of the barium, presence of the bile into the peritoneal cavity causes peritonitis. If there is perforation of the gallbladder, leakage of bile into the biliary peritoneal cavity, that will cause biliary peritonitis. There may be peritonitis because of the ischemia. So, there are other causes of peritonitis also. Peritonitis is recognized on physical examination by presence of severe tenderness to palpation. If it is localized peritonitis, there may be rebound tenderness. Remember, rebound tenderness is a feature of localized peritonitis, and guarding and rigidity is a feature of generalized peritonitis. So, this is how a peritonitis develops. Bacteria or any chemical that leads to the irritation, that leads to the outpouring of the fluid into the peritoneal cavity because of the increased permeability, and leads to the formation of fibrinous exudate, and inflammation will cause loss of peristalsis, and this loss of peristalsis will lead to the adhesion between the bowel and omentum, and that will try to localize the inflammation. So, any peritonitis in the omentum and bowel tries to localize it to prevent the wide generalized peritonitis. The features of localized peritonitis are pain located to one area, there may be fever because it is inflammatory condition, and there is a rebound tenderness. Rebound tenderness is a feature of localized peritonitis, and if it is generalized peritonitis, then pain is severe and nearly involving all of the abdomen, they will be made worse by moving. Tenderness and guarding may be there, and there will be absent bowel sounds because of the loss of peristalsis, and peritonitis usually leads to the third space fluid loss. So, leading to the dehydration and a circulatory collapse, we call it. And if this peritonitis is not treated in the time, then there will be extremities may be cold, clammy, because of dehydration there will be sunken eyes, tongue will be dry, pulse will be thready, and patient will be anxious. So, this all together called Hippocratic facies is suggest a perforation peritonitis. How to diagnose peritonitis? It is on the X-rays, X-ray chest or abdomen. It will detect free intra-abdominal air, and if you are suspecting peritonitis, but there is no free air on X-ray, then we might get a CT scan. USG is useful in localized peritonitis that occurs because of some inflamed organ like appendicitis, cholecystitis. So, if you are suspecting localized peritonitis, then USG is better, otherwise X-ray abdomen is sufficient, but if X-ray abdomen is not diagnostic in patient suggestive of peritonitis, then we get a CT scan. What is the management of the peritonitis? Again, we have to take the general care of the patient, means we have to rehydrate the patient, correct any electrolyte abnormality, we have to give wide spectrum antibiotics, put a Rice tube, Foley's catheter, provide proper or adequate analgesia. Then the treatment is depends on the specific cause or site of the obstruction perforation, and it is managed by surgery. Either we remove the perforated organ, close the perforated site, or we make an stoma and we do a thorough washing of the peritoneal cavity to remove any infected material from the peritoneal and put a drains. So, peritoneal washing, removal of all the infected material and draining the peritoneal cavity, because further there will be some collection of the fluid. So, that infected fluid again needs to be removed, and it depends on the site of the perforation what is the actual management. If it is gastric perforation, duodenal perforation or small bowel. So, we discussed them when we did talk about those organs in detail. Okay. Peritonitis is a lethal condition. If it is not managed at the right time, it may lead to the death. So, it carries the mortality of around 10 to 15%. So, this was all about today. It is from today's lecture. Remember that acute abdomen is a painful non-traumatic surgical emergency, and it is more commonly because of the perforation, obstruction, ischemia or inflammatory condition like acute cholecystitis, appendicitis, pancreatitis. And there may be gynecological causes like ectopic pregnancy or torsion of a ovarian cyst. So, they can present in the emergency, but there is a conditions non-surgical condition can also present with the acute abdomen. Okay. And the most important thing in acute abdomen is the pain abdomen, and we have to take the history of the pain in detail to make the diagnosis. Only the pain can lead us to the accurate diagnosis, and that might be supported by the investigations in the form of simple investigations of ultrasound and X-rays. Okay. So, this was all for today. If you have any question, otherwise you go for the attendance.